Okay, welcome to all the attendees for this evening's SADA webinar on Caries Management by Professor Joby Peter. We're just waiting for the numbers to stabilize before we start. There's still some attendees that are joining. We are 286 thus far, and we'll just give it about 30 seconds or so before we begin. Right, so my name is Yak. I'm from SADA Gauteng South. I'd just like to welcome Professor Joby Peter and thank you for giving us your time. It's 10:30 at the moment in Kerala, India. So we're not going to make too much of a hoorah about the welcoming. He's asked if we can keep it very brief. I'm sure he has better things to do at 10:30 in the night in India. But I'm just going to give you a brief explanation of Prof's biodata, and then we'll begin. So Professor Joby Peter is the Professor and HOD of the Department of Pediatrics and Preventive Dentistry in Malabar Dental College and Research Center in Kerala, India. He has completed his graduation from Mangalore at Mahi University, and thereafter his post-graduation in Pediatric and Preventative Dentistry at Annamalai University in Chidambaram. He has numerous national and international articles in various journals, and also co-authored a chapter in the textbook of Pediatric Dentistry by Prof. Damle and Dr. Shobha Tandon. He also holds a PG Diploma in Criminology and Forensic Science, whilst maintaining memberships in other associations such as the Indian Dental Association, the Indian Society of Pedodontics and Preventative Dentistry, the American Academy of Pediatric Dentistry, the Academy of Applied Myofunctional Sciences, and the Kenyan Association for Pediatric Dentistry, the Al-Iraqi University in Baghdad, Iraq, and the Lincoln University in Malaysia. This is something that I find quite interesting, is that Prof also holds a record in the Limca Book of Records, the Asian Book of Records, and the Indian Book of Records for traveling his car for 10,000 kilometers in 27 days, covering 13 states for the noble cause of a tobacco-free India. So, Prof, I hope your car didn't start smoking after that expedition. But on that note, I hand it over to you, Prof. Joby Peters.
Thank you, Dr. Yashkinki. Thank you so much. Am I audible?
We can hear you very well. Yeah.
Oh, thank you so much. Thank you so much. So, can I start the session now? Is it stabilized? The Zoom and the your YouTube links are stabilized. Can I start now?
Yes, you may begin.
Yeah. Do you have a? I want to smoke. Do you have a cigarette to smoke? A lighter to light? Let me tell you, I'm not a smoker. As Dr. Yashkin said, I campaigned against anti-tobacco campaign in India, tobacco-free India. Do you know that four times the people of South Africa have caries untreated compared to the smoking crowd in your community? According to the study done by Cape Town Vascular and Metabolic Study in 2020, only 17% of people in South Africa have smoking, but 68% of people in South Africa have untreated dental caries. And do you know that 83% of that DMFT index, 83% of that DMD, the component of that DMFT index is missing tooth due to caries, either extracted, called off due to dental caries. So my fellow dentist in South Africa, let me tell you, I have been watching your websites. I'm going to the website. The SADA is doing a tremendous job to uplift the dental community in South Africa. And the efforts are all preventive oriented. Thanks for this opportunity to expose into this dental caries management. I'll be talking into a different perspective. So just let me start share my screen. Yes, so I hope it is visible to all of you. The management and the caries is the least understood topics in any part of the world. You name it in India, where I'm practicing, you name it any country, dental caries is a part that is the least understood there. Today, I just want to expose yourself into the seriousness of management of caries from a different perspective. I'll be covering this topic because I am at 23 hours from you. I am at the southern tip of India, Asia, called Kerala. Ernakulam or Cochin is my town, and you are at Cape Town. It's almost like a similar climate, similar place. It is a must visit tourist destination at your time and will. So I will be covering a holistic approach of caries because I already told you, given you the importance, caries is not what you think. It's very alarmingly spreading in our community. To understand caries from a clinical perspective, the new paradigm shift in caries diagnosis and a little bit insight into white spot lesions. And one classification which I follow, practice, and get good benefits is ICDAS classification. I'll be talking about in detail about this classification. And believe me, I'm a pediatric dentist. I practice general dentistry also. But when I apply preventive dentistry, the effect or the result is rewarding. So I'll be talking at the end of this presentation little more depth about preventive dentistry, at least the fluoride therapy in your clinical practice. So each slide and each session is going to be little interesting, challenging, confusing, but at the end we have Q and answer session, and our moderator Dr. Yashin is going to help us to interact with you all in YouTube and Zoom. Mr. James is very close friend of me. He had a discomfort while he was jogging on a Sunday morning. He said, Dr. Joby, I'm having a discomfort. I want to sit. He sat and he said, I have a chest pain. I have this little discomfort. We rushed him to the hospital, and in the hospital, they took an ECG. There was a variation of the ECG. Then they took something called advanced diagnostic tool. They took a angiogram and they said there is a block. Dr. Joby, he needs a surgery immediately. I said, yes, go ahead. An open heart surgery was performed. He's doing well. He's saved. And he said, Dr. Joby, thank you so much. You are there at the point of time. So while the doctor was coming, he asked, Doctor, what was the reason for my collapse and my situation like this? The doctor said, when you came, when we checked your blood, it was all higher. You were at a higher risk of getting this condition at any point of time, and you had it and somebody was there to help you. So you are the higher risk category. And then he said, so what should I do? What should I do so that I can sustain? He openly asked, what should I do to sustain myself? Doctor said, no, you need something called diet modification. You need something called lifestyle modification. You need something called drugs to support you. You need something called multivitamins to sustain and support you. And you have to come and visit me every month. Then we reduce it or taper it down depending upon your situation. He said, yes, I will do that, because he has faced a fearsome situation there. This is called surgical management of a disease. Surgery was the only option here because he was at the last point to save the life. And nothing else can be done for him. And they did that. But after the surgical management, they told, you need to come down to this. But even, let me ask you, if he had a regular dental checkup, imagine if he had a regular dental checkup, regular follow-up with the physicians. When the alarm bell rings, the physician or the consulting person should have told him, modify it, follow it, practice it. You can see a difference. That's called medical mode of management of a disease. Medical model of management. You are preventing inevitable things that can happen, and you know it will happen at a future point of time with medical model of management of a disease. Forget about dental caries. I'm talking about a physical situation, medical situation in our society that is happening can be prevented with proper guidance. It can be done. A 45-year-old patient, Yasif, comes to the clinic with severe dental ache. He says that I have severe dental toothache. On examination, you can see on lower teeth, he has got a deep dental caries there. What we do at this point of time, we take the history fine, we take an IOPA, or an X-ray we take, or it's involving the pulp. So there are two options for us, either extract so that your pain will be subsided, or you have an option like a root canal or whatever. So you discuss with the patients, the options affordable, you do a root canal, or if it's not, you remove it, pull it out. That's the option there. But we focus on to that tooth, either root canal and crown, that's it. If a patient comes with a cavitation, food is lodging, food is going inside, what we do is do the filling. We just modify the cavity or clean the cavity, and after that we do a filling. So that is surgical management of caries. Exactly like the surgeon did an angioplasty, the surgeon did a bypass. What we have done here, we bypassed it. We filled that caries lesion with a cavity, with a filling, with the finest material that you have, you filled up like a surgeon who did a stent with the finest stent available in the market. He placed that. Exactly like that, you place the finest material available and sealed it. Yes, it is done. You go ahead, that tooth is filled, happy, go back. So surgical management, we have done there. Dear fellows, let me tell you, caries, management of caries from this to this, from the inception to the inevitable things that is happening, There is a time period that can happen there, and you can prevent it. So you start diagnose it correctly. Yes, there is a process that is happening. It will come into this. You identify it. You can apply the medical model of caries management and seal it there and prevent it there. Or you tell them, don't worry, nothing, no happens. And after 2 to 3 years, the patient comes and sits with you, and then you can go for surgical model like root canal and cap or extraction that can be done. So what is this dental caries here? What is this dental caries? Why our treatments are needs a change, or my fillings is not staying? Patient comes back, you do a MOD or a DO or MO. Patient comes back and say that it fell off, it's fractured, it's not correct. Do you think the occlusion is the problem? Do you think your filling is the problem, material is the problem? Do not blame the material, do not blame the thing. The basic thing that you have to understand is you forgot something that is happening in the patient's mouth, maybe a MO or a DO, but there is something is happening inside the mouth. Let us concentrate what is happening inside that patient who came for a filling. That is dental caries. So the definition of dental caries, if you see Schaefer's definition, if you see other definitions, there are so many definitions which says that, but one definition which I love you to follow is this definition by Caulfield et al. In 2005. Dental caries is an infectious and transmissible disease. So many times mother asked me, sir, I had this problem in my childhood. My daughter is also having the same thing. Is it related to family? I said, yes, it can get transmissible. Vertical transmission from mother to the child, it can happen. So it is an infectious and transmissible disease. The most important part of this definition is it's an imbalance of indigenous oral biodata rather than an the COVID-19 or the pandemic or any other disease is by exposure to the new pathogen. Viral disease, bacterial disease, you are exposed to the new pathogen, external pathogen. But dental caries is you have those pathogens inside your mouth which are normal commensals. They are not harmful normally, but under certain situation their imbalance happens and they become very harmful. That means mutant streptococci or streptococci mutants are normal commensals. Everybody's mouth. If you are born as a human being, you take the saliva, you have mutant streptococci in everybody's mouth. But they are not harmful. They are good commensals of our mouth. The moment imbalance happens, these people are very opportunistic. They are very opportunistic. The moment they see upper hand, they dominate. When there is an imbalance of this pathogen happens, you have a problem called dental caries there. So in diagnosing a dental caries, you might be visibly seeing with your mirrors, or you may be seeing with your naked eye, but try to understand that dental caries is a disease. Heart attack, the cardiac problem which I explained, is the manifestation of a greater problem that is happening. The attack and the symptoms and signs he showed, the shivering, the falling off, and all those things are signs and symptoms of a greater danger of a cardiovascular disease. The cavitation, the pits, the whatever you see in a patient, the manifestation is the signs and symptoms, but a big process of a disease is happening. That is called dental caries there. So if you can have a small patch, non-cavitated lesion you can have. You can have a dip or a discoloration. You can have a huge cavitation. You can have open lesion. All comes under signs and symptoms of a caries lesion. That's all. But there is something happening, like that patient has got something called dental caries as a disease. This is a disease. Now, if you ask that there is a cavitation, there is a cavitation, there is a cavitation, you can point out and pinpoint and tell me, Dr. Joby, this patient has got a 7 to 8 cavitation is there. Okay, fine. I'm not worried about the cavitation here. I'm worried about what is happening in this patient. He or she is suffering from something called a disease called dental caries, which inevitably affect every tooth or any tooth that is coming. So filling whichever tooth has got a dip or a cavity is not the solution there. You are not treating the disease. You are treating the signs and symptom. You're just trying to fill the cavity. That's not the end of it. Because it's a multifactorial disease. It's not a cavity that you see there. It's a whole process that is happening. This child is suffering from something called dental caries. You try to fill, it's not going to stay there. It's not going to be the permanent solution there. Because the child is suffering from a disease, dental caries. No matter, you might satisfy the parents and the patients by filling the cavities, but after 1 year, 2 years, 6 months, they may have new lesion, new cavity, same feeling that you did fall off, because the process of caries, that condition continues there. Look into these two cases, A and B. Just look into those A and B. Look into the molars. They are all first permanent molars. Can you come to the chat box and tell me what you feel the difference? Because I don't like a monotonous lecture. Can you see this A and B? What is the difference? What you feel? What do you feel? A and B. What is the difference in between these two cases? Do you feel any differences in between these two cases? Can you come to the chat box and tell me? Yes, Dr. Joby, there is a difference there. Yes, A is good, B is bad, or A is bad and B is bad. Is it possible? Is it possible for you to chat? I mean, I will be allowed to say that what you see is what I can teach you. If you say what you in A and B, I can teach you a lot in the next few slides. So I expect you, if anybody feels to come in the chat box and put your views between A and B, that will be great. Okay, so A and B, if you see, look at the fissures, the number of fissures. Look at the depth of the fissures. Look at how clean the fissures are in B and A. So there is a problem with the anatomy of the occlusal surface of a tooth. So this child A has high probability of getting dental caries because the fissures are deep. You know, so many fissures are there and they are very deep and narrow. But B has got a less number of fissures. They are wider, well collapsed. So self-cleansing property is very good. So less chance of getting. So one point is morphology of the tooth structure. Deep retentive fissures. Whenever you see a deep retentive, mulberry-like molars, if you see, there's a high probability of getting dental caries because of the fissure morphology there. Then sweets, definitely sweets are arch criminal, especially frequent dieting and the sugar are arch criminal. They definitely can support into formation of the dental caries. So frequency of snacking definitely will be the reason. Another, look at the condition. This is a 13-year-old. Look at that condition. This is another 16-year-old. This is another 21-year-old. Host factor. This is another 8-year-old. You can see in any age group, if you see, the oral hygiene is very bad. So host factor is also there. Patient's negligence or patient's inability to keep clean is one factor in caries management. Third one is agent. Definitely microorganism. You all know that microorganism. I'm not going to depth into microorganism can cause dental caries. Now, this is an interesting study. Very interesting. In my own clinics, I have done. This is a child with 8-year-old age, which came with just erupting molars, but uh, primary second molar had a deep dental caries lesion, and we managed with a conventional, conservative approach of management. She was 8, and we told the parents that see her permanent teeth are erupting. We need a every 3 to 6 months follow up because she's having a high caries pattern. Yes, sir. Parents accepted it. You know what has happened? At 10 years, the same parents came back with a condition like this. Luckily, my temporary filling of 8 years is staying, and now the problem is the permanent teeth, erupted teeth, which that time I told there is a risk. Now, at 10 years, the patient is exposing and telling them, sir, there's a problem. She's telling of pain. That deep tooth is having pain while having food. So, guys, there is called something called from 8 years to 10 years, something called time. Time also important. So at least every 6 months, if this patient would have reported, I would have prevented that is happening, but that didn't happen. The testimony, let me tell you, time is also important. So what I was talking about is the host, the flora, the substrate, as you all know, it's called the causes a disease that's called web of causation. So three things are must. Dental caries doesn't happen as it happens. It happens with a cause. It happens if there's a sufficient host, a tooth which is susceptible, a flora, that's a bacteria that is present, and sugar should be present. Then only it happens. That's called web of causation concern. But time is also added, especially with par with the dental caries. You need sufficient time for the process to take care. Why? Because there is something called a defense mechanism of the body. Try to prevent that. So, if all the other factors present and sufficient time is given, you will get a dental caries there. Oh, what a beach! Nice beach in Kerala. We have multiple beaches. So in South Africa, I'm 100% sure there are so many big because southern tip of Africa and in an Asian continent, India and Kerala is a southern tip, and we do have a lot of beaches there. Nice to be in beach, nice to relax yourself in the beach and the sun warm and suntan. Everything is very good. But will you keep your home or house? Will you build a house in your beach? The sands in the beach are not stable. You cannot have a good or a strong platform to build a firm structure in a beach. What about a marshy land? Will you build a home in a marshy land where it is all sunken? Will you build? You will never do that. Exactly the same situation, dear friends. You cannot do fillings and you cannot expect that filling to going to be stable in a situation like this because the entire tooth and structure are weak. No composites, no GIC is going to stay there because entire tooth structure is weak here. Because a process of dental caries is happening here, no fillings is going to stay there because enamel is weak here. If you want a fillings to stay there, you need a sound enamel. If enamel is very sound, your GIC and a composite will stay there. If they are not, it will fall off. Second thing I just want to ask you is, do you build a home next to a waste dumping yard where you have a filthy smell, unhygienic condition is happening near the home? Do you like to build a home permanently there? Now my question is, will you try to build a crown, a root canal, or a filling in a mouth where patient's oral hygiene itself is very poor and guaranteeing the patient that he's going to stay there? I don't think so. It's going to stay there. Oral hygiene is so poor, and none of your filling is going to stay there. Hygiene is very important. Potholes in India are very famous. In monsoons, you can see a lot of potholes are there, and you have to fill the potholes. And you need a apparatus or you need an equipment to fill the potholes. That equipment and what you are using now to fill and drill are almost the same. This person is filling the road or a field, you are filling the cavity. There is no difference in between that. And that sound of filling, every day we do that sound of filling and drill and fill we have. So the current concept is if you have a cavity, take the history, IOTA, fine, you drill, fill, and tell the patient this is the bill. If you can't, extract it. That's it. Drill, fill, and bill is the concept that is we are following it currently now. We have the finest of the equipments to drill, fill, and bill. But let me tell you, we have so many things to do that. So whatever we are doing is our all repairing it. You drill with the finest bar, finest your micromotor or your equipments, hand pieces, all are comes under repair. You're repairing it. You're cleaning it and filling it. You are repairing that. From so many years, even I am doing that. Repair center. Cavity is there, repair the cavity, fill the cavity. I have so many tools to repair that filling. But let me tell you, now what we follow is called healing center. We never use hand pieces now. Rarely use at the end we use hand pieces now. We foresee, yes, there's a danger that is happening. We diagnose that disease and we do something called healing centers. Let your clinic be a healing center rather than a repair, drill, fill, and build. No, let it be a healing center. You diagnose it, identify it, apply it. Let it be a healing center starting right now. So you have to change an approach. So I told you, you need a change in your pattern of diagnosing it. Then I told you you have to change in the diet and all. And finally, you have a change in approach, your concept of treating dental caries there. Because we still follow the old concept of prevention of extension of decay. That means if dental caries is there, you drill it and extend it maximum, even encroach onto the sound enamel so that extension, so prevention. You think that, oh, you have removed that black dot, brown dot. Oh, now let me keep the feeling. Now it is safe, is what you feel. Caries is not that black or brown spot that you see. That is a signs and symptom. Caries is a huge process that is happening because there is a definite reason. So web of possession, as I said, was the reason for us to manifest. There are three reasons. We are focusing on to the three reasons of host, environment, substrate. We have so much time to spend and learn about. These are the three reasons to cause a dental caries. We are relying on that. Then came sufficient component model where we started applying time and the associated factors also, which revolutionized caries management. So now we do not apply prevention for extension of decay. We apply sufficient component model of managing caries, where caries is a disease we understand. We know that what is the consequence of it. We know that It's not just the feeling that you can prevent dental caries. Associated with other factors that is causing is also has to be addressed. So we have a sufficient component model to prevent dental caries there. Depending upon that, we have medical model of managing dental caries. Prevent it before it appears there. Ecological approaches, latest approach, and Nexo model of caries. So many models depending upon this sufficient component cost model. So nowhere now you just drill and fill is not there now because we understand caries is as a disease there. So understanding caries as a disease is the first step in your practice. It's not just put some filling onto the cavity and say that it's done, go home. No. If there's a cavity, there's a disease that is happening. So you understand that. So we dentists should know disease is a dynamic process. Dental caries is a dynamic process. It's not just the disease that is happening. You have to change the mode of treatment and you should have a sound base to fill and patience factor and you have to change your approach there. So let me tell you guys, we have summarized the first session of my presentation is that understanding this as a disease now. It's not just the cavitation that you see. The cavitation is due to a disease that is happening inside the patient mouth called dental caries. And it's a dynamic process. It can increase, it can decrease, or it can stabilize there. Depending upon that, you need to change. No matter whichever best composite that you use Ivoclar, use a 3M, the best composite you use, a best generations of dentine or enamel bond you use, unless you understand caries is a disease process, nothing is going to stay inside the patient mouth. You have to diagnose that dental caries is a disease there. This year, 2005 to 2011, it's a golden era in caries management. Lots of changes and evidence-based ethical studies came out and changed the perception of managing dental caries. Let me tell you, first thing is understanding dental caries and dental decay is different now. Dental caries is a holistic or overall approach of caries process that is happening in a patient. That patient may or may not have a dental decay. For example, ECC or early childhood caries with and without cavitation or a white spot lesion, all the white spot lesion is happening, but no cavitation is there. So that patient doesn't have any dental decay there, but is undergoing dental caries. The disease is infecting him. After a week or a month, he will have a cavity there. So dental decay or cavity or the brown spot, white spot, whatever, what you see in a patient is the sign and symptom of an inevitable thing that is happening is called dental caries. So the differentiation, dental caries is a disease. Decay, dental decay, which is a common man term, what the patient say to you is the manifestation of the process of the disease called dental caries. Same way, caries diagnosis and caries detection. What it's all same, yeah? Diagnosis and caries, no. Caries diagnosis is a holistic approach. Why caries is happening? The multifactorial problem is diagnosed there. But caries detection is a simple process. You open the mouth, put the mouth mirror, see, okay, you have a cavity, it's a caries detection. You have a catch, it's a caries detection. That's a visual way. Or you can use a radiograph, you can use multiple methodology to detect caries. But diagnosis of caries is holistic. You have a cavity, okay. You ask the patient the diet, you ask the patient the habit, oral hygiene, everything you ask, and patients falls in the negative category, Then you say, okay, you do not follow oral hygiene properly, you do not follow sweets, you are frequent snacker, you do not follow of cleansing the mouth after a sweet thing. So that means, and you have this much number of cavity. So, and your salivation, your number of caries, your or periodontal or oral hygiene, everything is tabulated together and say that, okay, diagnose that you have a high probability of getting dental caries. And when you open the mouth and you see multiple cavities are there, you call caries detection. You have a caries in 1/6, you have a caries in anterior teeth, you have caries in the posterior teeth, you have caries in the buccal teeth. That is caries detection. For tooth, you are identifying and saying that, yeah, you have a cavity. But the entire diagnosis is called caries diagnosis. So in this child's mouth, if you see, this child is suffering from dental caries with dental decay. He is diagnosed with the dental caries and caries detection is also there. So whatever I said is there in this child. So it's not the cavitation that you see is important. But other than that, look at the other teeth and see the condition, what is happening inside the mouth, the multifactorial thing that is happening inside. And that's what a dentist has to see and has to prevent it. So how to diagnose a disease? Any disease. How will you diagnose a disease? You will ask the patient what you are suffering from. Patient might say, I have a pouch, there I have a cavity there, food is getting lodged, I'm a little discomfort, I have a pain, I have some signs and symptoms, the patient will say. What you have to do is verify the signs and symptoms. Okay, fine. You have a pain, you have a foot lodgement, you have a cavitation that you feel, or something that you feel. Okay, let me see that. You look into the visual examination, you will do that. Verification of that. You clarify your fine. Okay, whatever you said, there is a gap, there is a cavitation, there is a dip, whatever. You detect and confirm the signs and symptoms there. And you diagnose it as a disease. You do not say, okay, you have a cavity there, that doesn't mean you have a dental case. You look into other side. The patient might have said lower left region, I have a problem, pain. You saw that, yes, there is a problem. But you also look into the other side, upper and lower, all side you see and evaluate. You just diagnose it and tell, detect it and tell, okay, fine. That is the problem the patient is having, but otherwise, other side is also having a problem. All dental care is there. So initially, you might so something like this, and you might use verification methodologies like a probe or like a IOPA to detect that. But inside the mouth, a process called dental caries is happening then. Signs and symptoms are that cavitation, white spot lesion, catch, whatever you name is the signs and symptoms. But the process of a disease is happening called dental caries there. So how to detect dental caries? It's a very simple question to ask. How can you detect dental caries? So you understood caries is a disease now. Now I'm asking how to detect dental caries. How can you find that patient is having a dental caries? You all know that your probe is the one that used to help you to identify a caries lesion, and whenever you just run the probe, when you have a catch, you call it okay, patient is having a caries there. Catch is one criteria that we used to do. Now, the question now, can we use a sharp probe to detect dental caries? Is it reliable to use a sharp probe to detect dental caries? In the current understanding of dental caries as a disease there. Look at these cases. Look at this 12-year-old patient who has done an extensive treatment for a checkup. Look at this patient. There are some white spot or some bright lines you can see on the gingival margin of this patient's there. And you can see a close-up view, you can see some whitish discoloration on the enamel on these patients we can see. What are they? They are called white spot lesions. The new terminology called white spot lesion. What is this white spot lesion? They are nothing but subsurface demineralization. That means the surface is intact, but deep inside the enamel, they loses the hydroxyepithelial structure. The calcium and the phosphate are lost. So the deep inside the enamel prisms and the crystals, they are weak. That's called demineralization or subsurface demineralization. So if you see the picture, you can see the surface is intact, but inside what happens? Calcium and phosphate are lost and subsurface demineralization occurs. And that is what you see as a white spot lesion. So they are very fragile and brittle. So if you use a sharp explorer onto this white spot lesion, try to poke this white spot lesions, believe me, you are inducing a cavitation. That white spot lesion is not cavitated lesion actually. That's a subsurface demineralization happened there. You can remineralize that. But when you use a sharp explorer to poke in and find out the catch, you are literally opening up the lesion there. So it will create a lesion there. Second thing is this probe that you are using, you have started using the probe from one tooth to the other tooth. So you are inoculating the microorganism deeper inside because you used one tooth, then carried on to the next tooth. So the plaque and the material is on the tip of the probe and you poke it and you are inoculating the microorganism deeper inside and keep it safe at the deeper inside part. Export the microorganism from one side to the other side. That is why the current scenario in case diagnosis is that the tip of the explorer should move gently across the surface and the explorer tip should be always a round tip, should not be a sharp tip. Round explorer tip should be the best. Then the tip of the explorer should be moved gently across the surface of any non-cavitated area to determine the presence or absence of roughness there. This is according to George Tukey. He is a proponent who says that do not probe and white spot lesion. Do not use probe, sharp explorer or a probe to detect dental caries. So I went to an extensive chat with sir and talk with sir, and what sir says that there are some shift in the diagnostic tool. What sir says that there's some steps which you have to follow for initial caries diagnosis. And first step is dry the tooth. First step, any tooth you dry that tooth first. So how to make the tooth dry? What he suggests is use a toothbrush. I was really, I said, sir, yes, use a toothbrush. Tell the patient to bring the toothbrush and you just see how he brushes, or you only clean the tooth with the toothbrush. And once it is clean, then you evaluate. So no paste or anything, just clean the tooth with patient's own brush, or you give a brush on the day of appointment, let them clean the tooth with the brush, or you clean the tooth, which patient says that I have a problem and then try them. Even if you want, you can use your aeroter or micromotor rubber cup or rubber vessels to identify that. That's the first step there. Clean the tooth. Isolate and clean the tooth is the first step, and look into the tooth, what is happening there. Step 2 is dry the tooth. Once you clean and isolate it, dry the tooth. Look at this two picture. One tooth is cleaned but not dried. The same tooth which is cleaned and dried. When you clean and dry, you can see a difference there. You can see a whitish appearance of the enamel there. So that's a sign. That's a sign. That whitish appearance of the enamel when you dry without anything that you applied, just clean the tooth and you dried it. That shows that that white spot lesion is appearing on the labial, lingual, occlusal, any surface of the tooth is a dangerous sign the patient is having a dental caries in the initial stage. It's a starting stage. It's not a cavitation. It's a starting stage. Now, that is why George Stuckey says that if you use a sharp explorer and try to put a catch, you are going to make a cavitation, or you are going to poke these white lesions and make it a frank cavitation. That is why do not try to use a sharp explorer in initial caries diagnosis there. So what you need to do is just dry the field, isolate and dry the field, and look into this whitish appearance of the caries lesion there. If you want to clean, use a toothbrush and clean that area so that no food debris remains there. And dry the area and look into this whitish appearance occlusally, buccally, incisally, if it is appearing. That shows that the tooth is under demineralization. It is undergoing demineralization. That's why the white spot that is happening. White chalky enamel surface there. It can even happen in a primary dentition also. Whitish band like chalky appearance in a primary dentition also it can happen there. Now, if you want more diagnostic tools, advanced diagnostic, let me just give you the website address. Acton Sporolite is a light-induced fluorescent evaluator. Is a given spectra caries detection aid, Midwest caries, or a light fluorescent diagnodent, or a light emitted LED light emitted detection things, which can literally say that caries lesion is present or not. Let's see this. This is a beautiful article, Gomez et al. Detection diagnosis of caries lesion. If you want, you can read this, a 2014 article. All the latest diagnostic tools on detection of the caries has been well clearly mentioned there. So diagnodent or caries spot, that's all explained, which will give you an indication caries is present. It highlights the caries so that all those area which is shows as red might require a cavitation or may require your burr to intervene. Rest of the areas you can seal it. So you are limiting the process of wherever caries is happening or cavitation is happening, you do a filling. Rest of the areas you seal it there. Now you have diagnosed caries with different modes, but the simplest mode of diagnosis or visual inspection, which are step 1 and step 2 done, you will understand that caries is happening in a patient mouth or not. Now comes informed decision making for dental caries, that is management of dental caries. Now, why it is called informed decision making for dental caries is, believe me, in different parts of the world, in India, even in my part of the country, all people or all patient doesn't accept the protocols which we ideally want to follow. So we might need some clinically oriented points to them, informing the patients about how you felt about it. You know, yesterday we had a case of a 13-year-old who need two apexification. 13-year-old patient need two apexification in her lower first molar, permanent lower first molar. We had a discussion with the patients, parents, and informing the parents and making them understanding that this is not, this is your mistake or your ignorance or awareness that has led into the condition that is, your daughter is feeling it, made a lots of difference. They canceled their flight back to Dubai and staying back to finish the treatment, and then they go back. So informing the patients or the parents about the disease process that is happening and its consequence is very important to them. That now, dental decay or cavity, they are just signs and symptoms. Patients say food lodgement, food is getting lodged, I am getting pain onto that tooth. That is for that tooth only. But The other tooth, other condition, you have to explain and understand it. It's a multifactorial process. That decay or cavity is not happen in a day's time. It is a long-standing process that has happened. So you try to feel that it may not stay for a longer period unless you understand or make the patient that there's a process that is happening or risk assessment of the caries is happening or not. And severity of the lesion, how much deeper the lesion is, and prophylactic and therapeutic options for this. Yes, I can start preventing it now, like a prophylactic methodology or a therapeutic methodology or other way surgical management. Now, are they ready to accept the treatment is very important. You talk a lot, but patient or parents are not understanding. There's no point in talking, but you do your part, inform your part, that will be better. We have these assessment forms. Each patient have an assessment form is given to them. They fill this form. We do this form and categorize the patient into which category are they ready to accept the treatment. Knowledge, everything is assessed. Then only we put the patient into the treatment category. And to start off, we start with something called simple thing. Plaque disclosing tablets are available. It's very online. You can get disposable plaque disclosing tablet. Buy it and keep it in your clinic. Adults or pediatric patients, ask them to chew and spit and ask them to smile. They will get scared. They say, oh, am I a ghost or not? Or am I a witch or not? They may feel because of the plaque accumulation. Then they understand how good their oral hygiene it is there. So start with this to evaluate or educate the patients with that. Then comes how to manage the caries process. Now, that's a difficult task. Let me tell you, it's a very difficult task to convince the patients the process that is happening. What I do is I usually tell them about a soft caries, a soft tissue lesion. Imagine a soft lesion that is present there. It starts with an ulcer, a persistent ulcer for a long period of time. It happens, initial tissue changes that happens. You never know that initial soft tissue changes can become a benign lesion and then it can go to a malignant lesion with the different stages. Even malignant lesion has got a stages there. Exactly the same stage. Dental caries doesn't happen in a day. It's a multifactorial. Lots of time is required to develop it. That is why web of causation and time. There's a definite time that is required to develop it. So we need stage-wise classification or understanding of this disease. Once you have the stage-wise understanding of the disease, it's so easy for us to manage it. Like a benign lesion or a malignant lesion. In cancer lesion, you can tell the patient you are in stage 1, stage 2, stage 3. Oh, madam, you are in stage 4. There is no hope for you. You are in stage 1. You have good hope for it. Patient will accept it. Exactly the same way we can project in front of the patient that you are lucky. I identified it in a stage 1 situation. So you have a big scope. Sorry, you are in stage 4. I cannot help you. This is all left. Let's wait and see. But let's pull out the teeth. Let's do root canal and cap and wait for the success. That's all. So stage wise can be done there. So even caries lesion, a sound tooth, initial cavitation, deeper and deeper. It happens. Stage wise. So we need a classification which is not related to class 1, class 2, class 3, like GV Black classification is there, or any other classification is there. We are not treating the cavity here. We are treating the disease. So we need any disease have stages into progression. It starts, it, it shows you some signs and symptoms. It shows the severe signs and symptoms, final signs and symptoms, and done. Over. That's it. Caries starts with initial signs and symptoms, little more deeper signs and symptoms, little more and done. There's no other option. So in a patient, each tooth can have initial signs and symptoms or a later signs and symptoms. Sometimes a patient comes to you with a severe pain and swelling. Final signs and symptoms. Either option is pull out the teeth or do root canal and save the teeth. In that same patient, other tooth might be in stage 1, stage 2, stage 3. Why don't we prevent that? Why don't we diagnose that? That's called case diagnosis. That's called you identify a disease, not the signs and symptoms. Cavitation signs and symptoms. But you diagnose a disease. Why can't we treat that first? The initial stages, why can't we see? Second stage, what methodologies are there? Third stage, what methodologies are there? Fourth stage, what methodology? Each stage, how we can prevent each tooth into that stage. So we need a stage-wise classification system. That is why lots of evidence-based research went into this, and International Caries Detection and Classification, as well ICDS, has come into the picture, and they are modified into International Caries Classification and Management System, ICCMS system. Both are same, but they classify dental caries into stages, and each stages what you can apply, what preventive method you can apply. You can log on to their website. They have a home web page. You get a lot of articles and ideas regarding it. I follow according to their protocol. We start treating the dental caries. So let's see this ICDS system. This is system one. They are divided into codes. Code 1, 2, 3. A sound enamel where there are no caries lesion that is visually or visibly intact. So ICDS code 0. 0 means no caries lesion. Intact enamel, no caries lesion there. What about other system? Code 1. You can see a caries lesion, visible changes only after air drying, confirmed with pits and fissures. That means every tooth pits and fissure visible changes only if you air dry you can see. If you do not air dry, it is not seen. Code 1. That means the first change is visible when you dry the enamel. Like as you apply acid etchant, you acid etchant for orthodontics or for any acid etchant you apply acid etchant, and when you clean that and you dry that, you can chalky white appearance. Exactly that appearance comes in a tooth where you dry the tooth, then only you can see chalky white appearance, called code 1. Visible change only after air drying, confirmed within pits and fissures, not on the cervical area, only in the pits and fissures. Like so, chalky white area, you apply that. Code 2, distinct visual changes even without air drying. That means in a patient, wet condition, without even drying, that means saliva is there, no drying, nothing. You open the mouth, the patient, and you can see a distinct visual changes seen without even air drying. That is called ICDS code 2. That means little more severe lesion that is happening here. I have not dried that child's teeth. You can see a distinct visible changes. Even the primary dentition with very distinct visible change. I don't have dried. If I dry it, it will be more visible, but without even drying it, I can say it can be whitish or it can be brownish, maybe because of the stain that is happening there. So that is called code number 2, ICDS code number 2. Code number 3, localized enamel breakdown. There can be a localized breakdown of the enamel that has happened. That means the intact surface has broken down. There's a deep cavity that is being formed there. So that is called ICDS code 3. There is a localized enamel has broken down, but no visible denting. Enamel has broken down, but no visible denting there. ICDS code 3. Now, ICDS code 4. It's an underlying shadow of the enamel and dentin can be seen. You can see a small cavitation, but underlying shadow you can see. You can see a shadow surrounding that caries lesion. It can be also around a field restoration. Field restoration also you can see a shallow can. That's called ICDAS code 4. Look at this. All are ICDS code 4, where a small lesion but a huge shallow can be seen around the lesion there. That is ICDS code 4. Once you open up, you know it's a huge extensive lesion that is happening there. ICDS code 4 that is happening. What is ICDS code 5? Distinct cavity visible dentin. You can see it's open lesion. It's an open lesion, you can say. A visible enamel is gone, dentin is open, and some part of the dentin is exposed there. A visible lesion, cavitation, distinct cavity with visible dentin. Cavitation in opaque or depending upon the food habits and the nature, you can see either a pale or a dark brown or whatever you can see because dentin is exposed. Enamel is gone and dentin is exposed, open lesion. Any part of the tooth you can see. That's called ICDS code 5. And lastly, ICD, this is all ICDS code 5. Lastly, IDCS code 6. What is the ICDS code 6? Distinct, extensive, distinct cavity with visible dentin. Look at this huge cavity with visible dentin that is there. Extensive cavity, huge cavitation. An extensive cavity involves at least half of a tooth surface or possibly encroaching the pulp. You might require a radiograph to confirm whether the pulp is involved or not. And depending upon that, you have to formulate the treatment plan. So, it's an extensive lesion there. So, different category. Now, what is the importance of this categorization? This will help us to formulate the treatment plan. Look at this cavitation. Look at this, so deep it is. All are deep caries lesion where pulp is directly or indirectly involved there. So if I ask you in this patient, what are the code? Can you identify the code? I should say that this patient will have a code 4 because there is a cavitation but surrounding lesion. So it's maybe a code 4 for this patient. You can see code, it's already filled, but around that there is a cavity, there is a halo. So code 4, and this is code 6. You can see huge cavity with dentin exposed. You can see code 6. So this gives us an indication. Okay, this patient is stage 4, this patient stage 6. Stage 4, fine. You can tell the patients, let me clean up the cavity. Let me see that if possible, I will save that. Stage 6, definitely it's better to take an IUPA and tell the patient that, no, it's very deeper. There's a more conservative procedure. It's very difficult. You might have to go for radical procedures like pulpotomy or partial pulpectomy or a root canal might be required there. So that is the importance of this staging and informing the patient there. Now, these are occlusal lesions. What about the interproximal lesions? To understand the interproximal lesions, you might have to take a bite-wing radiograph, and that will give you the proximal lesions depth also. So you might have to read more about the ICDS classification of proximal caries also. I have talked about the occlusal caries lesion, proximal caries, IOPA, and or the bite-wing radiograph will give you a better picture. So that is accurate done. So visually, if you want to see, what I do is I use a separator elastic in between wherever susceptible tooth is there. I keep a separate elastic, call the patient after 3 days, and I check and I determine, okay, it's class 1, I mean stage 1, stage code 1, code 2, code 3, depending upon which stage that is. So separate elastic can be placed. Orthodontic separate elastic really help you to determine, and so that you can see the gap in between and determine which condition, which state the tooth is there. So what are the preventive? The last part, I'm winding off. The last part of the presentation is preventive treatment consideration. So you have identified there's a disease process that is happening. You have identified that stages there. Now, according to these stages, what preventive treatment consideration that you can do? Current protocol is drill, fill, and bill. Whatever happens, you drill. If a cavity is there, discoloration is there, drill, then you fill with the material and bill the patient. But let me tell you what the latest concept is: clean, fill, and bill. Why don't you apply this concept? Initial caries lesion, clean the lesion, do not force or cavitate the lesion, and there are methodology to fill or infiltrate the lesions and build the lesion so that you don't make a frank cavitation there. So treatment consideration for code 1, 0, absolutely no caries. So do not worry about it. Code 1, where there can be initial lesions are there. So one of the protocols that you can do is, if the patient is ready to follow the awareness and hygiene and follow-ups, you can manage this patient with simple follow-up methodology. But I should tell you, these patients better to prescribe some remineralizing agents. What are the remineralizing agents that is there? So these are all patient-related factors: patient's motivation, hygiene, awareness, willingness, all are patient-related factors. So you cannot rely completely on the patient. So what we do is we apply some remineralization techniques called GC mouse or MI paste, which are all CPP, ACP, which are remineralization protocols. So we ask the patient to apply these agents after your daily brushing. We cannot control their sweet habits. We cannot control their hygiene habit and proper follow-up and cost of the treatment also. They are not ready. So for those patients, what we do is, okay, fine, you are not ready for that. I mean, I can understand that, but at least do these protocols of remineralization technology. We tell them Trident, white chewing gums, or GZ mouse or MI paste, all contain remineralization solutions. And what does this remineralization solutions do? They have calcium and phosphate present. So when you apply these solutions or this paste inside your mouth, they cause remineralization. Let's see what happens. This is how you ask the patient, in an adult patient, to apply remineralization paste. You just ask the patient to apply this with your finger or a brush, apply on the upper arch, on the lower arch, and then ask the patient to hold it for 1 minute to 2 minutes and ask them to swish so that the saliva contains the calcium and phosphate, and then expectorate it so that maximum calcium and phosphates are available for remineralization. So whatever demineralization that has happened, this calcium and phosphate which is present in this solution especially have an affinity to the demineralized section, and they get bond into that segment, and so white spot lesion will be automatically converted into a full-fledged normal lesion there. What about code 2? Code 2 is a distinct visual changes even without air drying. What can we do there? The best option is to arrest the caries lesion. Here comes the arrestment of the caries lesion. How can you arrest? The preventive dentistry. Fluoride is one of the solutions that you can do to arrest the caries lesion, where fluoride gel or varnish or a foam can be done. What I use is gel foam by gel company. It's a 60-second application paste. Easily you can apply, faster penetration. The more you keep, the more benefits that you get, but at least 1 minute or 60 seconds sufficient. That's the gel that you get, gel from Pascal company, that we use it for the patients there. Then comes fluoride varnish. Amazing property of fluoride varnish, which high concentration of the fluoride is there. So if you apply fluoride varnish, once you buy, you have to keep it in the refrigerator. They are available. Fruit protector for Voco or Ivoclar, it is available. You can buy. It's an internationally reputed company. In your country also, it will be available in online. You can buy it and you can store it. Once you open it up, that's done for entire patient. So you can apply amazing results there. How will you apply fluoride varnish? Paint on technique. You just paint it on to the patient. Okay. For very young patient also, I will show you how to apply the entire procedure for fluoride varnish application. Initially, just clean the tooth with a rubber cup or the toothbrush. I told you Use of toothbrush. Just ask the patient to clean the tooth with the toothbrush without any paste. And gargle and come and sit there. Dry the arch. Bottom roll isolation is more than enough. Dispense into the well provided the fluoride varnish, and lower arch is applied first, followed by the upper arch. Because of salivation, more of dissolution can happen. So that's why you apply a lower arch, fastly apply, then you go to the upper arch. Use a high vacuum suction to absorb the extra and air dry and leave it for 1 minute to 4 minutes. More than 1 minute is sufficient to do that for fluoride application. Indication or fluoride varnish. Instruction to the patients. You have to tell the patient, do not eat or drink for 45 minutes to 1 hour. Ask the patient to spit maximum. Soft diet for the day. So you apply fluoride varnish, tell the patient for 1 hour, do not eat or drink. If he wants, do soft diet. If you want to gargle, tell them do not gargle, spit maximum on the day. Do not brush for the day, for 1 day. And you can expect a brownish discoloration because varnish may cause a brownish discoloration there. So
you will need gloves, gauze, and the
this is how you apply fluoride varnish for a very young child.
After washing hands, put your clean gloves on, which do not need to be sterile. You can put a small amount of the varnish on top of your non-dominant gloved hand. For infants and toddlers, the knee-to-knee position is very effective. The parent or caregiver holds the child facing her with the child's knees at either side of their waist. The child's head rests on your lap, and the parent or caregiver can gently hold the child's arms. If the child cries, as many will, this will actually help open the mouth. Use the gauze to dry excessive saliva from the tooth surface before painting the varnish. It is okay if some saliva is still there, as the saliva fixes the varnish to the tooth surface. Paint all the surfaces of the teeth, both the front and back of each tooth, and be sure to paint the chewing surfaces of molars.
So that's a very simple, very 2 to 3 minutes application procedure it is fluoride varnish. Now, what are the clinical uses? It's an amazing thing you can have in your clinic. Please don't mistake me. It's not only for your dental caries. Desensitizing piece, amazing result with fluoride varnish for desensitization. So lots of application of fluoride varnish is there. Even for the hypersensitive root caries, after crown cutting before temporary, you apply fluoride varnish, make it stronger, then you do that. And orthodontics, every orthodontic patient, fixed appliance patient should have fluoride application, especially varnish in between your appointments. That will be helpful to prevent the white spot lesions there. Otherwise, when you remove after a retraction, when you remove, you can see all the teeth might be a white spot lesion. To prevent that, it's better every 3 to 6 months you apply fluoride varnish in the fixed orthodontic. What about geriatric patients? Root caries, amazing result, desensitization. Fluoride varnish can really prevent that because patients may not be available for cavitation or root canal because of their condition, health condition, but fluoride varnish can literally help them prevent enamel root caries lesions in a geriatric patient also. So how many times should we apply fluoride varnish? This is something like low to moderate risk category biannual. That means every 6 months that is done. But patients with high caries risk, more than 3 to 4 DMFT, it has to be twice or thrice every 6 months. That means 3 months to 4 months every year. 3 to 4 months interval, you might need to apply fluoride varnish there. So 3 to 4 times a year would be ideal for a high caries risk patients there. And finally, code number 3. What is code number 3 of ICDAS is there is no dentin involvement, but enamel is broken down. There's a catch, there is a dip in the enamel. So I will be summarizing for this So in this patients, what can you do there? You can do one option is a sealant application or enamel biopsy. Only two options is applying a sealant or enamel biopsy there. So pit and fissure sealants are one option in conditions like code 3 where enamel breakdown is not certain, but it is present, but dentin is not much exposed there. So initial cases, you can do pit and fissure sealants. And what I use is 3M 10 Pro, one of the sealants which turn to white when you cure HelioSeal F and pit and fissure embrace wet bone. Even in saliva, you can use it. So these are the three ones which I use it. And before and after sealant application is amazing result you can get in a probable risk conditions. You can do that. Next is if there is a catch that is prevent, that's called preventive restoration, PRR, or enamel biopsy. That means in an occlusal caries lesion, only one pit has got a dip or a catch or an enamel or a dentin is exposed. Now, should I make it a conventional GV black kind of concept of extension for prevention, or the latest material which is available, biomimetic materials like a GIC, biodendine, MTA available? With that, can I do a newer approaches for minimal interventional dentistry, MID, or ART, a traumatic restorative technique? Can I do? Yes, you can do that, and that is called preventive resin restoration or enamel biopsy, where that particular area where that depth is there, that particular area only you go a little more deeper, remove the soft caries lesion. Here, even you can use Carisol or caries detecting dye, you can use it so that with the spoon excavator itself, you can remove the soft infected dentin, you can remain the affected dentin there, and then what you do is you restore it. You restore the tooth or the entire fissure with a fissure sealant, and that particular area you restore with a conventional GIC or a composite depending upon the material of choice, and rest of the fissure which are at risk, you clean it and close it with fissure sealant. So fissure sealing with filling together is called enamel biopsy or preventive resin restoration there. So to summarize that, code 1, the best thing if you suspect is remineralization techniques like your GC mouse or your recaldent technology, where you suspect visible lesion after drying or without drying. If you find, this will be the best approach to start in that lab. Code 2, arrest the lesion. We have to arrest the lesion with the various methodology which I have discussed that. Code 3, sealants or enamel biopsy. Again, your pit and fissure sealant or PRR come to that. And code 4, you go into surgical management. Now, surgical management, which is not the scope of this webinar, lots and lots of methodologies or newer methodologies for surgical management of dentin caries or caries approaching the enamel, all the other, or finally go for extraction. So to summarize, I have just covered code 1 and 2, and to an extent code 3. So remineralization and fluoride therapy can bring a lots of reward in that. Now, finally, do you know one thing? Just a moment that we dentists assume a lot. We dentists never explain things to the patients properly. We assume that patients understand or they may not expect what we are going to tell them. We fear a lot also. If I tell all this protocol, will they accept my treatment protocol? Will they not choose my clinic or go into some other clinics or not? And we try to ignore a lot. We do not upgrade a lot, and we do not follow up a lot. There are so many studies I can substantially tell you that dentist does a good job in filling, but follow-up is very bad with respect to the protocols to be done. So there is some amount of failure from our side also. I felt from our side also there is a failure in understanding this disease and promoting this disease. We cannot put all the blame onto the patient alone. From our side, we have to be a little more vigilant and explaining to the patient, keeping the patient track, record, and following of the patient is very important there. So dentist in the society does plays an important role in managing dental care. That is why every country you take, in my country, it is almost 100% of the patient, if you see, there are caries there. In your country, it is around 68%. So every country has a problem called dental caries. 260 billion people all over the world is affected by untreated dental caries, and 0.62 billion people, child 0.62 million child are affected by untreated dental caries. So it's a huge problem that is happening all over the world. So we need to be at our toes and collaborate with the association and try and understand cariology. It's a vast topic. I try to condense and try to give a broad outlook onto this within 1 hour maximum allotted to me, and because it's a bread and butter of our practice. Let me tell you, cariology, any part of the world, it's not implant, it's not orthodontics, it's not nothing. Cariology, caries management is the bread and butter that sustain our practice there. So we have to be very meticulously planned so that we do not do overzealous dentistry. So a small lesion, drill it, big it, make it bigger and fill it and say that, I fill it, shut it, go home. No, the other process that is happening as well. So we have to understand the speciality, and we have to approach holistic management of dental caries there. We have centers all over India where we train people with caries, with all the interceptive management. We have a meticulous hands-on program, offline program in India, in Kerala, in India. We are, but due to the pandemic, we are shut down, and that's why we are online. But you definitely can reach us, because there are so many programs, free online, free webinars are coming up. Do not miss free webinars like CBCT, the importance of CBCT, amazing programs, OPG, with a simple OPG, how can you diagnose and dictate? So many programs are coming up. With paid programs like sectional orthodontics, Dr. Binu, my partner, my friend, we are the person who have started online dentistry. So he's an orthodontist. So we have paid programs, filling up, the seats are filling up. And caries, this month end, we have a 1 full day, 7 to 8 hour program on complete caries management from inception to that. So you have the all liberty to come and join and be with us. So many programs and free programs, unconscious patient in your dental chair. One of the pilot faculty in India, a world famous oral surgeon, Dr. George Paul, sir, he is going to address you how to manage an unconscious. It's a free webinar that's going to come up. So any more details, clinically oriented topics, if you want, you can approach us onto this Facebook page, Insta, and all is available. Thank you so much. Your YouTube is also there. Thank you so much for this. I think I have extended a little more times allotted to me. Sorry for the delay. It's over to Dr. Yashin.
Thank you so much, Prof. And yeah, dental caries, it's like the potholes of the mouth. But I see there in that the one photo you showed of the potholes in India, it seems like an ICDAS code 2. Here in South Africa, we've got code 7. I wonder if our potholes have a classification. We must try and find that out. Okay, but let's move on, Prof, to some quick Q&As. I know right now it's 12 a.m. in India. It's tomorrow actually for you. So yeah. I'm going to get straight into some of the fundamental questions. Yeah, starting off with an anonymous, Dr. Anonymous, maybe because of this controversial question that he's asking. but I'll just put this to you. Do you think we as dentists should actively indulge in discouraging patients from consuming high energy soft drinks like Coca-Cola, Red Bull, Powerade, etc., refined junk foods, McDonald's and KFC, and drinking water that has a pH below 7? We seem to be avoiding this aspect of caries causation. What's your opinion on that, Prof?
Dr. Anonymous, let me tell you one thing, you cannot, on the day one, you cannot tell those patient to cut down all these things. The patient may not come back to you because he might go back, he may not come to your clinic, or he might go to some other dentist first and foremost. Now, the basic thing is, you know the pattern of the patient. You know the pattern, the diet pattern or the habit of the patient, and you know that that pattern is causing the dental caries. So why don't you apply fluoride varnish? Why don't you apply these agents and strengthen the teeth and get the confidence of the patient? And in the subsequent visit, tell the patients, why don't you stop? These things are things that can cause us more danger. Slowly, see the habit. As I told you, the cigarette smoking, it's not very easy to break the habit. It's very difficult to break the habit. Try to understand that patient is been having that habit or enjoying the habit for a long period of time, and he is not aware about the consequence of it. But we dentists know the consequences. So strengthen the enamel first, or the condition first. Apply fluoride and be with the patient, chat with the patient, gain the confidence of the patients, and then slowly one after the other. So the first thing I should say, that if he's taking carbonated drinks every day in a week, ask him to cut down into, within 3 days, you cut down, then within a 7 days, cut down, within a month, one cut down, reduce it. Amazing results you can get.
Okay, thanks so much, Prof. We had a question from Dr. Norman Clement. I'm just going to read his question and then subsequently answer his own answer to you, that maybe you can concur or not. His question was around dental materials and the use of composite and the longevity of composite versus gold foil for small carious lesions such as buccal pit caries. He was, well, he says he's old-fashioned and he still has his concerns around composite materials, but he subsequently says that you've changed his mind now, and although his old-fashioned ways are crumbling, he's willing to gain the acceptance in this holistic approach, and he also thanks you for this informative lecture. We've only got time for a few more questions because we've been cut to 20 to 9. So we've got about 6 minutes. Dr. Abhay Singh would like to know what is the use and the type of GIC9, and how can you use it in ICDAS 6 lesions? So
ICDAS 6 is a deep caries lesion. Yes. It's a lesion which I would suggest you have to need an IOPA, because I did not discuss in detail about the management of ICDAS 6. I stopped till ICDAS 3. More than that, you might put an IOPA and decide the patient, and you have to decide. GC, glass ionomer, is a biomimetic material. It's an amazing material that can be used, but I do not think that you have to blindly apply for all ICDAS 6 without IOPA and patients complying, and that decision has to be taken care.
Okay, thanks, Prof. A question from Dr. Yusuf Valley. I think this was pertinent to your caries detection insert of your lecture. He asked, what about arrested, recurrent, and active caries detection?
Detection of arrested, that rust lesion we call it as a rust lesion.
Rust.
That means, rust lesion. That means arrested lesion adjacent to a already filled lesion. So he's asking about the detection of that, right, Dr. Yashim?
That's correct. Yes.
Yeah. So these lesions require advanced diagnostic tools, which are already given you diagnodent and your fluorescence methodology, which I have told you. So you might require the advanced diagnostic tools for that. But doctor, if there is a arrested lesion which you have filled and the patient is having an active lesion on a filled lesion, you should not be concentrating on to that particular tooth. You should be concentrating on to the rest of the mouth. You just keep dry the mouth and see other lesions are happening there. But for this lesion, which you have mentioned, might require an advanced diagnostic tool to detect any arrested lesion or active lesion that is happening there. If it is there, definitely. Now, the protocol is that patient compliance are not much pain or anything. You remove the old lesion, clean the old lesion. You do not use any burr or anything. You use a caries detecting solution. Your carisol, or you have brisk 300 or 500, whatever. You apply onto that and remove the affected dentine, and then you temporize it and then go for a permanent filling.
Okay, thank you so much, Prof. We're going to take one more question from Dr. Ria Gupta. She asks if you can tell us the indications of oral probiotics and also the indications of a xylitol mouthwash.
So yes, oral probiotics, and that's ecological management of dental caries. I did not mention about in detail about ecological. That means you are altering the oral environment into a favorable environment. The definition of dental caries by Caulfield, if you remember my definition, it says that the normal commensals of the oral cavity are the one that causes dental caries. Depending upon this definition, this promotion of ecological management of dental caries has come. So you give probiotics which alter or which promote the oral ecology in such a way that those favorable bacteria which suppress Streptococcus mutans or control Streptococcus mutans or lactobacillus is being done. One among them is Lactobacillus casei. You might have heard about Lactobacillus casei, which is a bacteria that suppress the lactobacilli, which produce acids there. So if you supply or you give this bacteria, so it suppresses or controls that. So there are probiotics which are available in the market where you can supplement to the patient who has got high caries. Now, when you talk about this is specifically into those patients who are high caries risk. Now, high caries risk could be rampant caries or a caries eye, or patient who had hyposalivation like radiotherapy or those kind of patients. So you can actually substitute this kind of things, the ecological management or probiotics you can supply, and they will replace the oral ecology, and you can supply that and you can say wonderful effect. And second part of your question is like xylitol, chewing gums and all those things. Again, they also stimulate the saliva. They also have sugarless, so that this bacteria cannot use the sugar. Xylitol cannot be metabolized by the bacteria. So what happens is when you use a xylitol or induced sugar chewing gums, what happens is bacteria cannot use the sugar. So they, after a long period of use, they themselves reduce their counts because they cannot survive on to the sugar. So those things can be applied.
Okay, thank you so much, Prof. I think that's where we're going to leave it. And we're going to say good night or good morning to you. And thank you so much for joining us and for giving us your valuable input on caries management. And we hope you're staying safe there in India. I see that your area, Thiruvananthapuram in India, has actually got one of the highest numbers of COVID cases in India.
Yeah, after the election, yesterday was the election. Elections, we had a local election. We have a local body election that got over. So I mean, it's a spike. It is increasing.
Yes, yes. Well, we hope everything stabilizes, and we wish you all the best, and we'll look forward to hearing from you soon.
Thank you
Okay.
so much for the Sada. Thank you so much for the amazing opportunity given to me. Let me tell you, you are doing a tremendous job. As I told you, the study says that DMFT in South Africa is 68 and maximum is missing tooth. So you need to do a lot, and I extend my sincere gratitude and support to the Association of South African Dental Association for giving this opportunity.
Thank you, Prof. And likewise, we share the same sentiment. Thank you to everyone else that has joined us today for our CBD meeting. And yeah, hope everyone's staying safe, and a very good night to everyone. Thank you.
Good night. Good night.
Good night.
Good night, Doc. I'm going to end the session.
Okay, thanks, Norma. You may end.